All right, I might make a slow start because there's a number of people online now. So welcome everybody. My name's Robyn Mildon. I'm the Executive Director for the Centre for Evidence and Implementation, or CEI for short. I'll talk a little bit about what we do in a second, but just as a few housekeeping rules, can you please, well, firstly, for people that are in Australia, I'd like to acknowledge the traditional owners of the land that you are joining us from, elders past and present, and I'd like to acknowledge any Aboriginal and Torres Strait Islander people that might be joining us for this webinar. So folks, for you housekeeping, if you have any technical issues, please post it on the Q&A section of this webinar, the little Q&A, sorry, the chat, ignore me. The chat Q&A is for questions for Geoff while he's presenting and while I'm interviewing him. Please post questions as you think of them. I'm going to try and monitor that while talking with Geoff, and then read your questions out as they come in. So just keep that as a live stream. This is the second webinar that we've held as a series of webinars that we're hosting in the lead up to the Evidence and Implementation Summit that CEI and Monash University are co-hosting next year, end of March, Sydney, Australia. Please may we all be able to safely travel a little bit more by then. If not, I can guarantee to you, we are going to make sure that it will be an event that people can participate in some way face-to-face if they're able to and feel safe enough to do so, but also that people will be able to participate from all corners of the world in all sorts of creative ways we're going to come up with. So don't hold back putting abstracts in, get those abstracts in, because we will make sure that people are able to participate. We have about 450 people that have registered for this second webinar from over 20 countries. So let me say good morning, good afternoon, or good evening to Singapore. CEI has an office in Singapore. I'm hoping that you'll be new friends of ours. New Zealand, the US, Uganda, Philippines, Kenya, Ireland, the UK, Netherlands, Switzerland, and Italy, Falkland Islands, shout out to you, Colombia, Qatar, India, Trinidad and Tobago, South Africa, Taiwan. Apologies if I missed any country that you've come from. I hope I said Australia, probably not. There's a number of people from Australia joining us. And so welcome. And as I said, please use the Q&A channel to post questions that you'd like me to pose to Geoff as we spend the next hour together. So may I introduce to you the wonderful Professor Geoff Curran. Now, I'm not going to attempt to explain his background or his bio, but I have had the pleasure of referring to Geoff over time as Mr. Hybrid Design. And so what we are going to focus on here is the work that Geoff has done over the really last decade or so, I suppose, in terms of, it'll be longer than that, around what I think of as innovations in evaluation design. And so although some of this can sometimes come from what can feel like a very academic setting when we're talking about study design or evaluation design, the sort of work that we do at CEI, which is very policy focused, it's very practitioner focused, it's about using better evidence to improve the lives of people. The rigor and the quality of evaluation designs when you're testing and trying things really, really matters. And I've been taking with Geoff's thinking and work for quite a while. I will note that we have a range of participants. We've got academics, we've got policymakers, and we've got practitioners. So we're going to try and kind of speak to all those audiences, but don't think that this isn't relevant for you in some way. So Geoff, I'm going to ask you to introduce yourself. And then Geoff is he's got about 8 slides we're going to walk through just to give us a little intro around the type of innovation and evaluation and study design that he's been doing with his teams and his colleagues around the world. And then I'll start the interview properly and, you know, ask really hard questions and just make it really hard for you to answer them, Geoff.
It's
so
time
Geoff,
to stump
please.
the hybrid guy. So yes. Okay, so I will say first, I am a sociologist by training. and I'm a professor of pharmacy practice and psychiatry at the University of Arkansas for Medical Sciences. And I also there direct an academic center, which is largely focused on developing researchers in this field and trying to help people to work on their implementation research proposals and to try to help folks to get those research grants funded. I will say though that another goal of our center is to try to take some of the findings and learnings from the science and help apply those to our hospital and other state and local clinical care settings. So, you know, trying to translate, if you will, the findings from the science to help people on the ground, you know, to make effective change and to, you know, drive local QI efforts. So I've been in this field, you know, of D&I science for over 20 years now. A lot of the work is focused on developing and testing strategies, as we call them, to help support the adoption with good fidelity of evidence-based practices, or perhaps even strategies to help with the de-adoption of non-evidence-based practices or harmful practices. At the same time, I and my group have also spent time doing work on designs in this kind of science, methods in this kind of science, and that's really the focus of our session today, is this design idea, which we helped name and talk about and specify some years ago, and we're, you know, still refining the ideas on it now. So that's me.
Fabulous. Let's go. Let's have at it. Why hybrid designs? Tell us everything.
Okay, so I have a few slides here which I've culled from a couple of, you know, longer workshops where I go into more details on these what we call hybrid designs. And so the main idea here is that we thought that the whole point of our field really, which is the speed of moving research findings into routine practice, could possibly be improved by considering designs of our studies, of our evaluations that combine elements of clinical effectiveness research and research focused on uptake. Or to combine questions from both of these areas in varying degrees in the same project or in the same study. Some of the guiding thoughts were that, you know, maybe we don't need to wait for perfect effectiveness data on a certain intervention before moving into studying how best to support its uptake. Maybe it's possible to backfill, for lack of a better term, effectiveness data while we are focusing more of our efforts on testing these uptake strategies. And I'll talk more later about some of the conditions which, you know, might indicate that that's a good idea. But also we thought that these designs might help us to have a sense of how clinical outcomes, how intervention outcomes might relate to levels of adoption and fidelity. I mean, I think it's a common assumption, or it was, that uptake efforts, strategies designed to help people to, you know, adopt and deliver evidence-based practices kind of need to do it perfectly just like it was done in the effectiveness trials. But that might not always be the case. And if we don't study outcomes from both sides of this equation, we might not actually know, okay?
Yeah. Can I ask you a quick question?
Sure.
This is just define for people what you mean by uptake a little bit. I'm not sure. People will be familiar with the term outcomes. They'll be familiar with adoption or fidelity, but just what you've referred to uptake a couple of times. So just
yeah. So, uptake, is another word, which, I think really means the same thing as implementation, to deliver something, to adopt a practice and deliver it, hopefully with
terrific. Fidelity. Thank you. As you were.
So next slide, please. A few thoughts on, these hybrid designs before we talk about the 3 types which we have proposed. People were already doing these kinds of combinations, before I and my team started to speak and write about them. The first hybrid design paper, which floated these 3 types in 2012, really tried to bring some attention to them, to give some recommendations on what might be the best approaches to try this kind of thing. We looked for examples of these kinds of studies that were out there who maybe hadn't called themselves hybrids, yet. So, just to be clear that, we coined the term and we try to help people to apply them in a good way, but we didn't come up with the idea of trying to look at these kinds of questions at the same time. We're currently working on a review of 170 now published hybrid designs, and trying to code those to give a sense of how they're being applied, some of the stuff that's working, some of the stuff that's not, and also offer some new thoughts about their use to help people use them more effectively. And there's some recent papers too in the last couple of years that have offered some extensions, to these designs. The original paper focused on trials, meaning that we focused a lot on some element of randomization happening at some or multiple levels within these design types which we proposed. And a lot of people are actually, doing that, certainly. But a lot of people are using the philosophy or the concepts of these blends and not randomizing and doing one-arm type studies or studies of, clinical interventions or these strategies. And so for me at the moment, it's really about combining questions around the effectiveness of some intervention and what might be needed to implement it, or what are the strategies which we should use and test, okay? So next slide, please. Okay, so when I talk about these hybrid designs, I often do it in audiences like this, where we have a lot of different people from a lot of different points of view. They might have a mental health background or do a lot of work in primary care, or lots of different contexts, lots of different interventions that folks are supporting or wanting to support. And so I normally try to use some really super simple language to help us to get on the same page. I also use this slide to help explain sort of what implementation science is and how it might differ from more clinical research applications. So I will often refer to the intervention, the practice, the innovation that's being supported for uptake as the thing. And effectiveness type research is focused on whether the thing works. Patients, consumers who receive the intervention get better. Their symptoms functioning are better. Implementation research looks really more at how best to help people and places to actually do that thing, to deliver that thing. And in our field, we've coined this term implementation strategies to refer to kind of our interventions, or as I would say, the stuff that we try to do to help people and places to do the thing. And so what's often the main difference here in this kind of work is that the main outcomes that we study usually are implementation outcomes. And in more lay terms, that's basically how much and how well that these people and places are doing the thing, okay? So super simple language to try to communicate really what our science is, but also how it differentiates from some other types. Okay, so next slide, please.
I just need to tell you that my Twitter feed and my text messages just blew up with that slide. So I think that article is going to get a lot of downloads.
Yeah, after doing that slide a lot in workshops for a few years, I was asked to write a paper with the slide, and I did. And so that came out a couple of months ago.
And it's open source, so anybody that wants to go get that, you can get that. It's not behind a paywall, which is
Okay, so the last few slides here are really just a brief summary of these 3 hybrid designs which we proposed in the 2012 paper in medical care. And we proposed 3 different types: hybrid type 1, hybrid type 2, and hybrid type 3. Hybrid type 1 is focused largely on testing the effectiveness of the thing. Does the thing work? Okay, but there's a smaller element which is focused on trying to gather information on the doing the thing part. During the effectiveness study, how did the delivery go and what kinds of things might need to change if this were to be supported in the future if the intervention is effective in the real world. So learning about the implementation, the context, barriers to uptake, facilitators, and things like that. Flipping over to hybrid 3, it's kind of the opposite, meaning in a hybrid type 3 study, the focus is on testing ways to help people to do the thing. Testing implementation strategies, often in a comparative way. Strategy A, which has a package of strategies, versus strategy B in varying ways. But we still look at the clinical or patient level consumer public health outcomes associated with the delivery of that intervention, which was being supported by 2 separate strategies to help people to do it, okay? So a straight implementation trial does not look at those clinical outcomes. It only looks at those outcomes of adoption, fidelity. And then there's hybrid type 2, which is in one way a dual test of some intervention, some stated intervention, often in comparison to some other condition, and also a test of an implementation strategy. There are normally 2 different kinds of these hybrid type 2s. One is a dual randomized study where there's 2 different strategies that are being compared at the same time that 2 different patient level clinical public health interventions are being tested, or another variant where there is some patient-focused study, patient-level randomized trial, but the implementation strategy that is being used during that is being used at all of the places that are actually getting the thing. So it's more of a pilot test of a new strategy package that we're not really ready to see how it does compared to something else, but we're trying to gather some pilot data on its feasibility, acceptability, promise. So those are the three basic variants. I have a few more slides, which goes into a little bit more detail on each one. I don't know if you think that's
Let me ask a couple of questions.
Point,
yeah,
right?
Yeah,
and
yeah,
you know,
yeah. Let's go a couple of questions, and there's a lot of people online, so please, guys, guys and people, post questions. I've got the Q&A window open. I can spot it. I've got my Twitter feed going crazy. I've got you can just start throwing some questions up there, and I can have a look at that. I'm going to reinforce the first question that's come up here, Jeff, because I was trained as a behavioral psychologist and think that that's the way everything should go. So there's a question here. Would you consider developmental evaluations of policy implementation a type of hybrid model? For example, an evaluation that continually considers how well the thing is working, as well as how well implementation strategies are supporting people to do the thing.
Yeah.
You want me to read? Yep. Do you take that?
Yes. Yep. Yep. I mean, I think it certainly makes sense with the general philosophy. And I think that in that case that there might not necessarily be defined comparisons and randomization, you know, that there might be some more sort of a rollout design that is iterative, you know, where both the intervention and the strategies might be being adjusted over time to kind of maximize their performance.
Got it.
Is how I'm taking that. Anyway.
Yeah. I would say yes too, Emily. That's a really good question. I've got another one here, but she says thank you. No, thank you. Which hybrid type would best fit for qualitative research or for quality improvement research?
Okay, that's a great question. So I will talk about the qualitative first. So qualitative is used usually quite a bit in all three. I think it serves a central function, certainly in hybrid type 1. If I could actually go to the next slide, which gives just a little more look at hybrid type 1. So here we are talking about a conventional effectiveness trial, but there's a process evaluation that is trying to explore how the implementation went during the trial. And that is normally a qualitative focused approach or a mixed methods approach. And so I have never done and have never seen a hybrid type 1 proposed that didn't have a qualitative element to be part of that effort, okay? So that is, I would argue, a prerequisite, as it commonly is when really anybody is trying to study the context and try to understand barriers, facilitators to uptake of some intervention. For hybrid type 2s, I think that especially in the case where there's one strategy that is being pilot tested, if you will, there's likely going to be a lot of qualitative work to help to understand how it's operating, how it might need to be adjusted in rapid cycles, and to help to understand how feasible, acceptable, those strategies are. So I think that in both cases, especially qualitative research is often used and is very, very key. I think that thinking about QI designs, which might not randomize to this same level, I think that the principles apply. We have a new program at our place now, like I indicated, where we are trying to, train clinicians who are on the front line, who are doing QI work in D&I principles and some of these methods. And, really all of their projects are looking at a combo of things like reach, adoption, fidelity, but also clinical outcomes too.
Yeah, cool. Okay. I'm going to switch to something that sort of happens in our world all the time. It certainly happens in the other countries CI works, up in Singapore and the UK, and I know it's common for your work, Jeff, and that is, what about when you get that call, whether it be from a research grant funder or, in our case, a government or policymaker, or perhaps a philanthropist or a service provider, and they want to roll an innovation out quite quickly that has very limited evidence for it.
Yes.
So what about innovations that don't have much evidence? How can hybrid designs, can hybrid designs help with that? Because
yes.
And how can they help?
I definitely think that they can, and in some way, that's one of the key uses for, I think, especially hybrid type 3s, possibly even hybrid type 2s. When I started in my career, I started doing a lot of work in our Department of Veterans Affairs, which is our largest single-payer healthcare system in our country. And as one might imagine, that there were many, many times when there were mandates that were happening for understandable reasons that you will roll this out now. For example, suicide prevention interventions, which for understandable reasons, there's not a lot of RCT data on suicide prevention interventions. And there's evidence, but it varies. It comes from varying kinds of places. But there was clearly a veteran suicide crisis and the desire we need to do something rapidly. So a number of these interventions and processes were chosen, and we are going to roll this out starting Tuesday.
Yep, we're all familiar with that call. Very
yes,
familiar.
and so one of the things that we were able to do, was to work with the system to develop some of these hybrid type 3 studies to basically work alongside this rollout effort that was happening from the system, and to basically consider the rollout strategy that the healthcare system chose as the comparison condition, or as the uptake as usual condition, around which we in our research world wanted to test augmentations to that to see if we could do better. And we worked with people to, devise, if not cluster randomized studies, but stepped wedges or other kinds of designs, even rollout adaptive designs where, we would add strategies to places that weren't performing well in the uptake of it, all the while studying as much and as well as we could these effectiveness outcomes and feeding that back to the system to help them to know what's actually working, and also trying to tie how the strategies were performing with uptake, but also with any association that they might have with better effectiveness also. And in a hybrid type 3, that's what it's for.
Right.
Is look at how the strategies are doing with uptake, but how adoption and fidelity ultimately relate to these outcomes, these clinical outcomes that lots of people, especially system managers, clinicians, policymakers, care about the most. You know, those are the those are the outcomes that they want to change most. And we want to make sure that as we study uptake, that we show that our strategies that are driving in increased uptake and better fidelity also result in better outcomes that they care most about.
Yeah, cool. I think this question's related to it. I think so. To be considered as a true hybrid design, would the effectiveness aspect of the study need to be experimental, or is quasi or non-experimental sufficient, even if it is not ideal? Thank you, Catherine.
So like I said before, when we were writing the first paper, we hemmed and hawed. It took us two years to write it. And it's because we looked at other kinds of variants. We had an observational study version, and what about QI designs and rollout designs and things. For clarity of the first round of talking about these, we kind of said, okay, we are going to focus on, trial designs where there's some randomization. It is clear that, people are applying these philosophies to other kinds of designs, quasi-experimental studies, observational studies. And I think that is fair. I mean, as somebody who, was, raised in the academic tradition, and I learned a lot about, randomization and RCTs are the gold standard and all that stuff, I understand that. And I certainly want to be as rigorous as possible. But I also know, and I often say to people when I, teach on these and other designs, our designs are only as good as our clinical and operations partners allow us to do. And so if there's not an appetite for understandable reasons for cluster randomized trials or X, Y, and Z, and they want to look at other approaches, I'm all for it, and just trying to build in as much rigor as possible. But my own philosophy is, this is more of a philosophy and not a dogma about a specific kind of randomized approach or something like that.
I think a lot of people will be relieved to hear that, because we get kind of stuck in the to randomize or not RCT versus everything else,
Sure.
So that you sort of present the idea of a continuum, which is really nice. Somebody else has asked, what are some of the challenges to hybrid designs? How do you determine, for example, whether problems in implementation affect clinical outcomes?
Yeah, I think that there are a lot of problems with this, or sort of challenges, and, we only have about 25 minutes left, and we could probably spend them all on this. I will mention a few things. I think, for the researchers, one of the problems is that there are some folks, who really don't want to speed up. And reviewers get, they really want to see that next clinical study with people with green eyes, just to make sure that this thing works with you know, every micro group. I don't feel that way, and I'm in more of the let's hurry up camp. But I do know that there are people who struggle to make the case that the evidence is clear enough for us to make these kinds of blends and to study uptake questions at the same time that we're dealing with effectiveness questions. So that's one challenge. I think another challenge for hybrid type 3s that is common is trying to balance the data collection with the primary outcomes being more of these reach, adoption, fidelity measures, but also trying to get useful and helpful and good effectiveness outcomes. For some studies, some of those outcomes are more readily available, A1Cs or blood pressure. For PTSD symptoms or other things in mental health, those aren't readily available usually. So for a hybrid type 3 in some areas, primary data collection is necessary to try to make that happen. And in that case, sampling is often needed. Power can be affected. So there's some challenges there. I think the biggest challenge comes in some hybrid type 2s where your clinical effectiveness study is depending upon at least a base level of quality of the strategies to support enough reach and adoption and fidelity to not ruin your effectiveness study. Because in that part of it, right, the intervention has to be delivered well enough to have a good test of its effectiveness. And so for those kinds of designs, one has to really be careful and monitor closely how these strategies, which you have hypothesized that they are going to be successful and be feasible in the real world, you have to monitor them closely to see that they're working and not wrecking your effectiveness trial. And if they do, you have to step in and make changes to not ruin that part. So there are challenges. I also think that there are challenges associated with having the right expertise on the team to try to make sure that, you know, both sides of the study are being conducted well. And, you know, folks are, have the expertise and training to do their part well. And it often calls for a larger team than might be normally, compiled for a study which might be looking at, one or the other side in a non-hybrid way.
Okay, got it. I'm going to read this question because I just love the last bit of it. It may be a little bit kind of left of center for you, Jeff, but let's try it. Otherwise I can help.
Okay, sure.
Vast amounts of literature on evidence-based informed policymaking draws its foundations on medicine and has been escalated by policy practitioners in other fields. How can we relate this ancient IEPM, not sure, evidence-based informed policymaking, or IEDM, evidence-informed decision-making movement with hybrid designs? Is this old wine and new skin?
So I am going to need a little bit of help for you to translate that for me. I really come from more of a clinical research background and less about policy. So I might need a little help with.
I think I could try it. I mean, if I'm interpreting the question right, I don't think it's old wine and new skin. The reason we got very attracted to the work you were doing and this concept of hybrid designs is the reality of using evidence in policymaking, or the evidence-based policy movement, is we need designs that do a better job at testing the effectiveness of the implementation and how it relates to outcomes. Because for a lot of time, we're jumping straight from an innovation to just monitoring outcomes. And sometimes we're not even doing that. Or we're not iteratively trying to figure out the effectiveness of the thing because it's just been launched out of nowhere. So what I like about your work and your colleagues' work is that you're sort of, even despite coming from a kind of a very staunch academic kind of field and you know, community, to me, the growth of hybrid designs, I think, relates to just the reality of how you are asked to do evaluation work, and how important it is to do as much rigorous evaluation work as you can, which takes a lot of training and a lot of kind of innovation. So I think it's helping the evidence-based policy movement, and we'll continue to help it as we get better at these designs. I don't know.
And I would say too that, I mean, I think that the concept of the thing and doing the thing applies for lots of different kinds of interventions. And I think policies likely sort of count in here too. You know, even in the clinical world that I work mostly in, there's single interventions, there's guidelines, which are kind of policies. I mean, it's a collection usually of evidence-based practices with a frame of please use all of these in a certain way and follow this sort of set of, well, if this happens, then you know, do that. There's bundles of interventions that we treat as one evidence-based thing, but they've never actually been bundled in that way before. And so it might be 4 interventions that each have their own evidence base, but they're bundled and we don't really know how they work as a bundle. So, I mean, I think, or I've always thought that this approach is generic and I think covers policy, guidelines, individual practices. I mean, I know that there are people, you know, that are using these approaches with policy analyses, you know, and not just with individual practices, you know, in clinical settings.
Yeah. It's a slightly technical one coming at you, and I just lost it there. There it is. But so again, I think a little related, because I think people are trying to think about, some people are asking quite technical questions, which is terrific. And some people are trying to think about, how is this different? How is type 1 different to process evaluations? Is that just another type of processing? But I'll read this question out and let's see if we link this in. So are there any criteria that you use to assess which hybrid design is most suitable? If so, what would they be? Why don't you answer that first, then I'll go to the second part.
So yes, and I thought about putting slides in on that. I have sort of a new 6-question process to try to walk people through basically what they know, what people know about the evidence so far of the thing that they want to study, what they know about the extent to which it needs to be adapted to possibly be delivered in a new context, what people already know about the context in terms of the barriers, facilitators to uptake of that thing. If someone else has already tried to support the uptake of something in a place and we know that it failed, so we have kind of a starting point of a strategy that has failed. If we've already pilot tested some new strategy, and or how the components of the strategies we're contemplating, compiling, or testing have performed in other similar studies to support the uptake of other things. And so by answering all of these questions, and I'd be happy to share this flow document, we sort of give people off ramps to likely start with a certain hybrid design. For example, you know, if the evidence base is really good in this population and that context, but we don't know a whole lot about there, but we've already learned a little bit about the barriers to uptake of that thing there. A hybrid type 2 might be a pretty good place to start. And, you know, all of these hybrid types have these conditions that we've laid out, which seem to indicate that that's a good starting point, and I'd be happy to share it.
Yeah, so people are asking for that. So they would love the flow document, apparently. So if you can send that, folks,
Yes.
we'll figure out a way to get that to you.
Yes.
We're going to go to time for a couple more questions. And I want you to put your last, Nikki, can you go to Jeff's last slide where it just shows a couple of his articles? Because we're going to.
So I do have a point to make about how's it different than a regular process evaluation. So yes, a hybrid type 1 has a process evaluation that is largely to somewhat focused on what happened during the effectiveness trial. So what was that process? How it's different is there also needs to be an overlay where, often driven by some sort of determinant framework from our field, which helps guide you to common factors which seem to drive uptake, and then use that to take that process analysis further and to ask people, often qualitatively, to talk about, okay, well, if you were to try to keep doing this thing, how would the implementation strategies need to be different in order to help you to do it? Or speculate about places that haven't been part of this study but might want to adopt this. What do you think that they would need? What are the barriers that we saw during this study, and what kinds of barriers do you think that you might find in naive places who weren't part of the effectiveness study? A new thing that we're recommending for this hybrid type 1 evaluation is to not just ask these kinds of questions in the sites where the effectiveness study was, but to seek out naive sites who weren't part of the effectiveness trial, but would be the target audience for the intervention in a future rollout, and go tell them about the intervention and how it worked, and then say, okay, well, if you wanted to try this here, what do you see the problems as? What kinds of strategies might, you think that you might, need? So it's not just a study of the process during the trial, but it's a forecasting process to what strategies might need to happen in the future to help support it, and also how the intervention might need to be adapted moving forward to be more easily implementable.
Cool. Here's a nice little question for you that kind of tries to get some of this generalizable. So, do you know of hybrid designs used outside of health/clinical settings, and how well they've worked? Maybe engineering, art, software, manufacturing, or even politics. Jeff.
Oh boy,
he's a super smart person that asked this question, and he's always throwing that kind of politics thing in. So
I love it. In our review of published hybrid designs, we are focused on those kinds of studies that use the terms, and mostly what we are seeing are healthcare interventions, prevention interventions, health promotion interventions, and to some extent policy analyses. Haven't really seen, or frankly even looked for, some of the same notions going outside of the health realm. I think it's a cool idea. I mean, I can't imagine that there wouldn't be people who are trying to look at some of these same issues outside. A lot of the strategies, in our field that we test have come from engineering and lots of other places. So I assume so, but that's not something that we've looked at really yet, but it's a cool suggestion.
Okay. Okay, I'm going to take one more question here, and then I've got a fantastic question. So people need to wait for that one, and then we'll close out. So we often have a huge amount of data available, and choosing the way to synthesize them can be challenging. Do you have any suggestions for processes or strategies to best triangulate implementation data coming from a combination of administrative data, i.e., who seems to be getting the service, for how
Yes.
long, and what did they get, with
Yes.
more qualitative information, i.e. client experience, staff perceptions of barriers and facilitators?
Yeah, I think that is a great point. And there are some really cool ways to do that. And I'm part of a process now in our country trying to consult with people who got funded through a certain initiative to largely do effectiveness trials. And we're trying to help them to basically turn all of them into hybrid type 1 stuff. And so we are starting with some of the quantitative stuff that they're already measuring. You know, who are they approaching to take part in the study? Who is saying yes? Who is saying no? And some of that is quantitative and, you know, fairly standard stuff. Asking people to look a little more closely about characteristics of this reach variable that we call it. You know, what kinds of people are more likely to say yes and take part and say no and not. And then to add a qualitative piece to try to understand some of what's happening there relative to who is accepting the invitation, who is being, you know, who is saying yes to being part of the study, who is saying no, and why. And also doing the same thing if it's in a clinical setting around providers who are often being asked to recruit their patients for taking part in some of these clinical effectiveness studies. We often find that while people ask all the providers in these places to be part of the study and to talk about the intervention and refer patients to it, lots of times most of the people that end up in the study came from a relatively small number of providers, and lots of those providers didn't even really take part in approaching patients. And in our field's language, that's poor adoption at the provider level during the effectiveness trial, which is data to be explored. So we do lots of things like talking with high and low referring providers to try to get a sense of, okay, well, why did this intervention seem to really get you excited and you sent a lot of patients to it, and other people like, how come you didn't send anybody? And this kind of stuff is very helpful to understand issues like reach and adoption during these kinds of trials, and helps you to plan for the next steps. And we think if you do this kind of stuff earlier during these effectiveness trials, you are saving time and learning more about how you need to adapt strategies, adapt the intervention to be more easily delivered later on.
Fabulous. Now, a couple of people, we don't have time to do it because I think it'll take us, but a couple of people have asked to see the slides on type 2 and type 3, because I think we just looked at type 1 and skipped.
Yes.
So just have a little read of that. Let's not have Jeff, because I've got one more question for him, and then I have to tell you about a couple of other, remind you of a couple of things, so don't drop out yet. Jeff, I need to just get your opinion on a band that we've heard of. There's, I think they're referred to as Mullhead. Am I getting that right?
Oh my gosh.
Mullhead.
It's actually called Mulehead.
Mulehead, that's right. Sorry, I can't read my own writing. And there's a single called Finer Thing, I believe, available on Amazon.
That is a record. So yeah, so you found the
And you know somebody in that band, do you? Is there someone?
Yeah, so I am in that band. I've been in bands since I was 14, and that is a band that I've played in for about 20 years here in Arkansas. We have 5 or 6 records, and
there we go.
Yes, so that is the Weekend Warrior events which happen in my household.
Because folks, Jeff is not on social media at all. And I had some very good help from a mutual friend of ours, Jeff, to track that down about you. And you can thank them later.
She was telling on me. And that's not the only band. I have other bands too, but I'm not going to say anything.
Final slide, Nikki. Final slide. Just have people have a quick look at that. Type 3s. I thought that was going to throw you. We actually tried to figure out if we could get one of the songs up, but I just thought the tech was going to undo me.
We have videos and stuff too, but I'm glad
you're sort of more into it than I was expecting. Final slide, Nikki, for the next. So Jeff, that was fantastic. Well, I'm going to take a shot at these comments. I can see Twitter going a bit crazy. I can see the attendees kind of stayed steady. That's super, super. So you're very generous with your time. I know it's in the evening there. I know these sort of setups aren't easy. For everybody else, we've got another one in July. You can see the details there. AEST is Australian Eastern Standard Time. So we'll release more information while it's there. That's good. Thanks, Nikki. But Jeff, you're a rock star in more ways than just academia. So it's a delight. And if you can stay on, Jeff, we'll just have a quick chat.
Yes.
And everybody else,
yes.
You can hang up. Oh, somebody's posted. Somebody's posted a link to the music. That is hilarious. All right. Thank you, everybody. If you can, you're all dismissed, if you like.